Ashmita, what's holding up?
Ma'am, you can start.
Okay, please, Ganavi.
Good evening and a warm welcome to one and all. I, Dr. Ganavi, on behalf of the Indian Thyroid Society, will invite you to this day, that is 25th of May, where the world comes together to observe the World Thyroid Day with the aim of raising awareness about thyroid disorders, to promote early detection and to encourage individuals to take proactive steps to maintain a thyroid health. So before we start, let us briefly go through the journey of the Indian Thyroid Society. So Indian Thyroid Society was established and registered in 2003. It's a national body of healthcare professionals with special interest in thyroid disorders. It includes endocrinologists, endocrine surgeons, nuclear medicine physicians, general surgeons, and ENT surgeons. ITS is a member of the Asia-Oceania Thyroid Association. It has currently nearly 2,000 members. So the executive committee, we have the founder president with us, Professor R.V. Jaikumar sir, and our current president, Professor Sarita Bajaj madam. Also in the executive committee, we have our past president, Professor Rajesh Ratput sir, secretary, Dr. Arun Menon sir, treasurer, Dr. Mini G. Pillai ma'am. Vice President, Dr. Himagirish K. Rao sir, Scientific Committee Coordinator, Dr. Pramila Kalra madam, Joint Secretary, Dr. Shujai Ghosh sir, are all members of the executive committee. Also, Dr. Shashank Joshi sir, Dr. P.K. Jabbar sir, Dr. Krishna Sheshadri sir are all members of executive committee, including Dr. Mohammad Riyaz sir, Dr. Sushil Gupta sir, and Dr. Ashraf Jani sir. So the aims of the Indian Thyroid Society is to organize academic activities for healthcare professionals, to promote public education and awareness about thyroid disorders, to encourage research in thyroidology, and the publication in the flagship journal, Thyroid Research and Practice. It has state-of-the-art publication, and also it awards fellowship of the society, and it encourages membership of the society. So the ongoing academic activities of the ITS include the CMEs, the updates, the symposia, and the conferences. The thyroid clinics, initially held weekly, fortnightly, and now monthly, have numerous academic programs like journal clubs, case conversations, monologue, dialogue, panel discussion, meet the professor session, quiz, workshop, CPCs. So the programs endorsed by the Indian Thyroid Society include the Thyroid Awareness Week between May 22nd to May 28th, the World Thyroid Day, which is celebrated on May 25th, and the Thyroid Awareness Month, which is celebrated annually in January. So the research activities by the Indian Thyroid Society includes the provision of annual grants for original research studies focused on thyroid and related disorders, preferably in the Indian context, where the research grants are available online, and the details can be accessed in the website, that is www.indianthyroidsociety.in. So coming to the flagship journal, that is Thyroid Research and Practice, it is published twice a year in print and online with a quick turnaround time, with the electronic copies available ahead of print. So the fellowship of the Indian Thyroid Society is awarded to the ITS members with expertise and experience in the field of thyroidology. It will be selected by an expert panel, and the eligible members will be conferred the Fellow of the Indian Thyroid Society. So the textbook published by the Indian Thyroid Society includes the ITS textbook of thyroid disorders, the editors of which are Rajesh Ratput sir and Professor Sarita Bajaj madam. The guidelines by the ITS include the thyroid disorders in pregnancy, that is the consensus statement of Indian Thyroid Society, by Dr. Rajesh Ratput sir, Dr. Sarita Bajaj madam, Sujai Ghosh sir, Pramila Kalra madam, Arun Menon sir, Mini ma'am. It is published in TRP 2023. The upcoming guidelines include the management of subclinical hypothyroidism, which has been sent for publication, and also the thyroid nodule. So other guidelines published are the management of dyslipidemia and thyroid dysfunction, hypothyroidism and diabetes, and management of depression and thyroid dysfunction. So coming to the annual Indian Thyroid Society conference, that is the ITSCon, it is going to be held in Kochi this year between 27th and 28th of May. So there is a pre-conference workshop, that is the thyroid ultrasound workshop on 26th of May. Also we have the thyroid cancer symposium, that is the recent advances, on 28th of May. Also on 27th of May, there is a surgeon symposium with 2 interesting panel discussions. And the most awaited, that is the quiz, will be held on 27th and 28th of May. The prelims 27th and the final on 28th. The website of the ITS can be accessed through the site that is the Indian Thyroid Society.in, which has numerous contents that is linked to guidelines, access to ITS journals, records of all the academic events, and also the online membership portal. So the membership is awarded to all the medical practitioners in India, and there are two types of life membership. That is the full-time life membership and the associate life membership. It is the membership amount is about 2,950 rupees. Full-time life membership is awarded to the specialists in the field of endocrinology, endocrine surgery, and nuclear medicine, whereas associate life membership is for all the other registered medical practitioners. So the memberships are, the applications are invited online on the ITS website, which can be accessed through the link that is indianthyroidsociety.in. With that, I welcome one and all again for the webinar organized by the Indian Thyroid Society, that is the World Thyroid Day webinar, where we have both national and international faculty with us, discussing on the different aspects of thyroid disorders, that is the management of hyperthyroidism in both adults and children, followed by quiz, and then an interesting talk on subclinical hypothyroidism, when to treat. So before we begin, we shall now start with the introduction of the most distinguished dignitary, Professor Sarita Bajaj Madam. I request Dr. Pramila Kalra Madam to introduce Dr. Sarita Bajaj Madam.
Thanks, Dr. Ganvi, and good evening, everyone. It's my honor to introduce Madam. Madam is the present president of Indian Thyroid Society. She's an endocrinologist, and she is also the past president of RSSDI. She is also the founder president of South Asian Federation of Endocrine Societies. She is the president of Women in Endocrinology and Diabetes position also she held. She is the past president of Endocrine Society of India also. And she was the editor-in-chief of ESI Manual of Endocrinology, the second edition. And Madam has her areas of interest in diabetes education, thyroidology, and growth disorders. She has around 143 publications in both national and international journals. And Madam has been a guiding force behind all these webinars, which we have been conducting for the past 1.5 years. And she is guiding us even now also. So welcome, Madam.
Thank you. Thank you. Thank you, Pramila. Good evening, everyone. And it's a pleasure to have all of you with us for this very special World Thyroid Day 2023. A very, very warm welcome to all our faculty, especially the president of the International Society of Endocrinology, a very dear colleague and friend, Dr. Saeed Abbas Raza from Pakistan. We have Dr. Sharmeen Jahan from Bangladesh, Dr. Prashad Katulanda from Sri Lanka, and Dr. Pratosh Gangadhar from Kozhikode, Dr. Sara Alam from Dubai, Dr. Arpit Garg from Patiala, and of course, Dr. Shashank Joshi from Mumbai. Pramila will be conducting the entire session, which was to follow. That will be a panel discussion. And it's a pleasure to have Dr. Jabbar with us, who will be the chairperson. As we know, World Thyroid Day is celebrated on 25th. It's a global healthcare event that aims to recognize the burden of thyroid disorders, comprehend patient experiences, and honor those who have worked to understand and treat thyroid conditions. The aim is to create awareness and get people to thyroid conditions, their causes, and the available treatment options. So initially, it was decided in 2007 when members of the Thyroid Federation International got together and declared this particular day. It was chosen to honor the birth of the European Thyroid Association and was formed on 25th May 1965. The European Thyroid Association has been the pioneer. Other international bodies like the American Thyroid Association, Latin American Thyroid Society, Chinese Society of Endocrinology, the Asia and Oceania Thyroid Association are all supporters of this initiative. The theme for World Thyroid Day 2023 is Thyroid Health, Nurturing Well-Being. I think we are all aware of how common thyroid disorders are and that there is a need for an efficient and effective strategy to manage thyroid disorder. I don't think there is any other disease, or let us say gland, which has so much, because we have World Thyroid Day. We celebrate World Thyroid Week as well. And there is Thyroid Awareness Month, which is for the whole of January. So I think the importance of this organ or gland cannot be emphasized more, considering a lot of days that are supposed to be spent in promoting activities in the context of thyroid disorders. Thank you very much. Over to you, Pramila.
So thank you, ma'am. So I think all the panelists have joined. If they can all switch on their videos, it will be nice so we can have discussion. And I request Dr. Jabbar to give us the permission to start so that we can start the proceedings for the panel discussion now.
Yeah, warm good evening from God's own country, Kerala. President Dr. Sarita Bajaj. My teacher, Dr. R.B. Jayakumar, is a founder president of ITS, is also in the crowd. And distinguished guests, it's my duty to introduce my own friend, Dr. Pramila Kalra, to the audience. I think it's a superfluous to introduce Dr. Pramila Kalra in front of this audience. However, since we have a system, let me introduce Dr. Pramila Kalra. She is a very, very eminent personality, good orator, good teacher. Currently, she is heading the Department of Endocrinology, MS Ramaya Medical College, Bangalore, and she is having a lot of publication in her credit, and she is one of the very, very active member of various professional forums, including Indian Thyroid Society. Let me introduce Dr. Pramila Kalra for conducting the procedures. Over to Dr. Pramila, please.
Thanks, Dr. Jabbar, for the kind introduction. So I'll be starting the panel. So it will be nice if all the panelists can switch on their videos. It will be good so that we can have a good discussion. So starting with the panel discussion, we have the panelists, Dr. Syed Raza, Dr. Sharmeen, Dr. Prasad. Oh, we are going to have okay, good. We have got the CVs. So we have Dr. Syed. Dr. Syed is a consultant diabetologist, endocrinologist at Shaukat Khanam Cancer Hospital, Pakistan. And currently he holds the office of the president of the International Society of Endocrinology. And he also has served as president of organizations like South Asian Federation of Endocrine Societies, Pakistan Endocrine Society, and American Association of Clinical Endocrinologists, Pakistan chapter. And we also have Dr. Sharmeen Jahan with us. So Dr. Sharmeen Jahan is Associate Professor in the Department of Endocrinology at Dhaka, Bangladesh, and she has published around 45 original articles in various journals. And she is also a principal investigator in various other clinical trials as well. So can we have the next, please? So Professor Prasad, can we have his CV, please? He's a professor of medicine at the University of Colombo, and he is a consultant endocrinologist at the National Hospital of Sri Lanka. He is the past president of Endocrine Society of Sri Lanka, and he is also the past president of Diabetes Federation of Sri Lanka. He has more than 150 research publications to his credit. Can we have Dr. Pratosh CV, please? He is also a senior endocrinologist at Kozhikode, and he has many publications in peer-reviewed national and international journals, and he has authored various chapters in endocrine textbooks. And his areas of interest is management of hyponatremia and use of novel glucose lowering monitoring systems and endocrine hypertension. And he was also Dr. Sara. Dr. Sara is from Dubai, and she is a specialist endocrinologist at Canadian Specialist Hospital, Dubai, and she has around 25 publications to her credit. And she has been a gold medalist in MBBS and first rank holder in MBBS professional exams as well. And she has multiple other prizes to her credit. So after this introduction, we can just start the panel for today. So today's panel is for the discussion of basically thyrotoxicosis, and more so we are focusing on hyperthyroidism here. So when we talk about, Dr. Pratosh, when we talk about hyperthyroidism or overall thyrotoxic disorders, how much is the prevalence? Like we all practice in different types of places and different setups. So in your setup or in your place, how much is the prevalence, and overall, what is the prevalence?
Yeah, if you look at the data from India, we have a data from Cochin and conducted by Amrita team Dr. Usha and team. And this was conducted in around 900 patients, and they found that the prevalence of thyrotoxicosis, so hyperthyroidism, is around 1.3%. And that as scenario, if you look at the prevalence of subclinical thyroid disorder, hyperthyroid disorder, it was around 1.6%. And overall, whatever data I looked into from India, that leads to same picture around 1.3, 1.6%. And similar to the Western data from the UK, Europe, it's 1.3%, and in US, it's 0.8%. So it's almost similar. We have similar prevalence of hypothyroidism from data from India.
So any of the other panelists would like to comment from their country, because we know that little bit difference is there in different countries, but we know that overall it's not much different. But anybody else would like to comment on this? So if we have no comments, we can go to Dr. Syed. So Dr. Syed, what are the varied presentations you see patients coming with thyrotoxicosis have? Like we can let's say thyrotoxicosis, we can say hyperthyroidism, but we are going to discuss, Dr. Sharmeen will in the next will tell us about the differences when we say thyrotoxicosis and when we say hyperthyroidism. But just to start the discussion from Dr. Syed, like how do you see what all the different varied presentations are in your practice, and which all departments they mostly go, or do they directly come to the endocrinologist?
Thank you, Pramila. And again, it's wonderful to be part of the team, in a team for thyroid disease. And again, I see the president, and I want to thank Dr. Sarita Bajaj for inviting me, and again, rest of the team inviting me here. Pramila, I think we cannot. This is a just perfect opening sentence, opening question for a talk or discussion today. The reason I say this is, unfortunately, people who present with the disease symptoms sometimes don't have the disease. And again, people who have no symptoms have an underlying thyroid disease. And that's a tricky question, because if you look at the signs and symptoms of in that case, hypothyroidism as well, if you ask everyone in the panel, we got about 60 participants in it, I can swear at least 90% of them will have more than 4 to 5 symptoms of what you would see in hyper or hypo. So that's the problem with the thyroid disease. So usually you can see from the, and what I also say is that thyroid and diabetes are one of the only disorders, or one of the few disorders, which it can affect from the top of the head to the bottom of the feet as well. So again, symptoms could be anything and everything. So these people present with a whole array of different problems, and sometimes, and when you check the levels, they're perfectly fine. So I would not label one single symptoms with this disease possible. I think unless you look for it, and the proverb goes like, your eyes don't see what your mind doesn't know. If until like you're looking for it, you would not know the answer. So palpitation, weight loss, this is something we're going to discuss in next question as well, are all signs and symptoms, but biochemical evidence of a disease is more important.
Absolutely agree that no matter whatever the symptoms patient has, we have to confirm that biochemically. But we know that, as you rightly said, that they may go to varied doctors, they may go to cardiologists with palpitations, they may go to even the neurologist sometimes with muscle weakness, they may go to the orthopedician with osteoporosis, they may go with fractures as well, and they may even manifest with hypercalcemia. So there may be so many varied presentations, and they may go to the gastroenterologist with GI disturbances. So there may be so many varied presentations of the disease that sometimes it is very difficult to pinpoint, and we may have more of patients not having the disease manifesting like that. So it's as you rightly said, we have to investigate if we have a doubt. So Dr. Sharmeen, just to carry forward from there, we are using two terminologies, thyrotoxicosis and hyperthyroidism. So how do we exactly differentiate? Are these two terminologies the same, or there is some difference? And I think for the IT people to add, there are many people are named as Dr. Syed. So can we just rename them, because it is creating a lot of confusion for the audience? I think the IT team can take care of that, please. Yeah, we can go ahead, Dr. Sharmeen, please.
Thank you, Dr. Pramila, for your nice question. I would like to thank Dr. Sarita Bajaj and the Indian Thyroid Society for inviting me to this webinar. I've come all the way from Bangladesh, though in online. I work as Associate Professor of Endocrinology at BSMMU. That is the largest and the single medical university situated in the heart of Dhaka city. The question that you asked, the difference between hyperthyroidism and thyrotoxicosis, these two terms are often used interchangeably, but they are somewhat different. The subtle or the classic clinical manifestation that occur due to excess level of thyroid hormones in blood is called thyrotoxicosis. All thyrotoxic patients are not hyperthyroid patients, but all hyperthyroidism are thyrotoxicosis. So what is the difference? When thyrotoxicosis occurs due to hyperactivity of the thyroid gland itself, then we call it hyperthyroidism. As for example, the autoimmune activation in Graves' disease, the toxic multinodular goiter, the toxic adenoma. These are all hyperthyroidism as well as thyrotoxicosis. Also, the HCG-mediated stimulation of the thyroid gland, the molar pregnancy, the pituitary secretion of TSH, the TSH-OMA, these are also examples of hyperthyroidism. However, when there is destruction of the thyroid gland that causes inflammation and liberation of preformed hormones in blood, then it is called thyrotoxicosis, but without hyperthyroidism. In these cases, the preformed hormones are liberated due to destruction of the thyroid follicles. It could be immune-mediated, like in case of postpartum thyroiditis, or it could be viral or bacteria mediated, like the subacute thyroiditis. It could be mediated by drugs like interferon alpha, lithium, or amiodarone. So in these cases, the patient will have signs and symptoms of thyrotoxicosis, but the thyroid gland will be suppressed because the source of thyroid hormone is outside the thyroid gland.
Absolutely. So you have very nicely alluded to the points to differentiate. So Dr. Sarah, carrying forward from there, like we were discussing about the common manifestations of thyrotoxicosis, but that's very easy for anybody to pick up, and people will definitely suspect. But there are situations when we see that patients remain undiagnosed for years together because they may have some atypical presentations. So can you just allude to the atypical presentations which we see and which you have commonly see in your practice, where you suspect as an endocrinologist that this could be thyrotoxicosis or hyperthyroidism?
Good evening, everyone. And first of all, thanks to Dr. Sarita Bajaj, madam, for inviting me for this discussion. And this is a very interesting question. Like, we all are aware of typical manifestations like heat intolerance, weight loss, and anxiety, tremors, fatigue, palpitation. But there are certain times when hyperthyroidism remains undiagnosed for several months and even years. So such manifestations, they are more common in elderly people, which is called as apathetic hyperthyroidism. In that condition, it's absence of classical adrenergic manifestations, and it can manifest like lone atrial fibrillation, or just like feature of low mood, or even it can be diagnosed as depression. Then we have seen some patients with hypokalemic periodic paralysis, and they would come to the emergency with weakness. And unfortunately, many of these patients are not diagnosed on time. Then there can be even manifestations like only malabsorption or features of hypercalcemia, or it can be like in children also, like weight loss is the common presentation, but sometimes it may present as weight gain as well, and attention deficit hyperactivity disorder. I saw one patient with atrial fibrillation who was getting treated from a cardiologist for 1.5 years. And after that, he was found to have severe hyperthyroidism. So it happens. And sometimes primarily skin manifestation can be there. And also, like just now discussed now, since everybody has access to Google, Chat, GPT, then we have patients who are very much convinced they have hyperthyroidism or even hypothyroidism, but biochemically they are normal. So we have both ends of the spectrum.
Absolutely, rightly said, Dr. Sara, because this is a very valid point, because we do see so many people coming with the investigation and they are very sure that they have thyroid issues, and they think that that is the cause for all their problems. So it may be both atypical or it may not be actually there, and those are all the things which we as endocrinologists have to pick up. So taking up from there, Dr. Prasad, we know that so many patients are going to be diagnosed on time, but there are so many patients who are not diagnosed on time, and either they don't take the treatment, or they default, or they come with problems and they come with a thyroid storm or a crisis situation. So what are the varied manifestations of when you suspect a patient having a crisis? Because these are the patients who will come to the emergency, and they may come to cardiologist or other department rather than directly to the endocrinologist. And then we come into the picture when the thyroid hormone levels are done, or there is a huge suspicion, obviously, because the patient has many manifestations which give a clue that this is definitely something to do with thyroid. So what are the varied ways where this we suspect or they can present to?
Good evening, and also greetings from Colombo, Sri Lanka, and my thanks to Dr. Sarita Bajaj and the team for inviting me. Actually, this is very true. Actually, thing is, we need to have a high index of suspicion if we are to catch thyroid storm or thyrotoxic crisis in time, because we know that thyrotoxic crisis, this is very common in older people and extremes of age. Therefore, all doctors generally should know that there's a condition like this, and then we need to have a high index of suspicion to diagnose early, and to also, because treat them effectively, because if they do not diagnose in time, there is quite high mortality in this condition. So people who would come to us, generally, they are febrile, quite dehydrated, agitated, and then they are having tachycardia, and they might have quite, sometimes atrial fibrillation, and also they might have high output cardiac failure with a lot of, ankle edema, raised jugular venous pressure, and then cardiomegaly, and I have seen several patients who have got severe thyrotoxic dilated cardiomyopathy, actually. So, and I think I told about the fever. If you carefully take a history, unlike people who, due to sepsis, due to infection, these people had been gradually unwell. So they don't suddenly become unwell, and they had, over a period of, maybe days or weeks, lost weight, and then got these symptoms and gradually become unwell. The other important thing is a fair amount of these people have been anyway having a thyroid disorder. Either usually thyrotoxicosis, but they have either gone into spontaneous remission in graves and then neglected, no follow-up. And then some people have on their own, when they become better with symptoms, they give up, their anti-thyroid medications. And very rarely, I have seen a couple of patients who have undergone this iodine-containing contrast studies, or bypass procedures, that sort of things, without proper control, and even other surgeries. So those are the sort of patients who are at high risk of thyrotoxicosis. And any patient who comes with these sort of symptoms and then have a goiter, and also you should this should ring a bell that we may be dealing with sort of thyrotoxic crisis. And definitely, since thyrotoxic crisis can be precipitated by any infection, you cannot be 100% sure that you are dealing with only pure and simple thyrotoxic crisis. So anyway, somebody presenting like these symptoms, you need to have a high index of suspicion. Take your bloods for your basic tests, blood culture, urine culture, and then your full blood count, CRP, procalcitonin, and then the bloods for the thyroid, and then manage with perhaps broad spectrum antibiotics. And then when you suspect, if there's a high index of suspicion that you are dealing with thyrotoxicosis crisis, and then if the patient is not very extremely sort of having low blood pressure and so on, then sometimes starting on beta blockers also can be useful to control the heart rate, and then other the sort of symptomatic measures, supportive measures like controlling the fever, and all these things are very important.
Yeah, absolutely rightly. And sometimes we do really see that patients who are severely toxic and they go for radioiodine ablation, they may come with a crisis. And these are also some of the situations which we have seen in our practice. And carrying away from there to Dr. Pratosh. So Dr. Pratosh, we know that like Dr. Prasad was talking about the manifestations, and we know that normal management with antithyroid drugs may be a little bit different as compared to what we do for a crisis patients, because that's an emergency. But first, talking about the antithyroid drugs, like we always, there is a skepticism among the patients, because when we tell them about the problems or which they can develop, they are sometimes skeptical about it, and they are a little bit worried. So what are the things we have to keep in mind when we are starting the antithyroid drugs, and what are the guidelines we follow for starting the ATDs? And if it's a crisis, then how does it differ as regards to the antithyroid drug management?
Okay, antithyroid drugs generally, we do have some minor adverse event, as well as minor adverse event usually happens with the cutaneous adverse events like pruritus and allergic manifestation. But we are really worried about the rare but it's serious adverse event that include agranulocytosis. Although the prevalence or incidence is 0.3% in a large data systematic review, but this can happen within 3 months of initiation in around 95% of the patients. So one should be aware of this adverse event. And about diagnosing agranulocytosis, any febrile illness in an individual with thyrotoxicosis, you are initiated antithyroid drugs, then you should consider this as a possibility, especially if they have pharyngeal pharyngitis or oral ulcers or other symptoms related to that. And in that scenario, WBC count and differential count one should do. That's the current ATA recommendation 2016. But there's an interesting take in the European Thyroid Association recommendation 2022 for the pediatric graves. What they recommend is at baseline it's better to do WBC count, because graves per se can have some leukopenia. So it will lead to a confusion in the later period if you're not done a baseline WBC count. So this is a good point, probably we should take into consideration. But ATA currently says there is no need to do diagnose agranulocytosis in the you don't have to repeatedly do CBC in follow-up. But regarding the other adverse event we really worry about is hepatocellular dysfunction. There's a bit differential kind of hepatocellular dysfunction happens with methimazole and PTU. PTU generally produces a fulminant hepatitis hepatocellular dysfunction, which is a scary thing, and it is common in pediatrics as well as adults. And that's why pediatric recommendations said against initiating PTU. And they generally prefer carbimazole or methimazole in pediatric population. And the incidence is around 1 in 2000 fulminant hepatitis in pediatric population. And if you look at the methimazole, it leads to a pattern of cholestatic kind of jaundice. It's not the hepatocellular pattern of jaundice. And generally, incidence of hepatic dysfunction is a bit higher with PTU. And that is why PTU has got a less reputation now, and we often use it in the first trimester of pregnancy nowadays. But routine there is no recommendation to monitor liver function tests in patient on ITD, but if they develop any symptoms like pruritus or discoloration, yellow discoloration, or loss of appetite, or any suspicion of hepatitis, one can do the liver function test. Otherwise, there is no need to repeatedly do liver function tests in patients on antithyroid drugs. And other rare adverse event one should come across in patients on ATDR. One is ANCA positive vasculitis that one should aware, and the rare adverse event that often we endocrinologists come across is an autoimmune hypoglycemia syndrome, Hirata syndrome, that can occur with antithyroid drug treatment. So these are uncommon things, but the most important point we need to highlight is that these are very rare. We don't have to highlight it often to the patient. You should monitor it and then manage accordingly. That's what the take.
Absolutely. Well taken. Yeah, that's absolutely. So Dr. Sayed, like this is like simple case, like we have Graves, we have treated with antithyroid, we have a toxic nodule. Okay, we have given ATD. But now everybody is not Graves or toxic nodule. And we do see in our practice, and I think all of you will agree, that a lot of patients who are actually not needing antithyroid drugs are put on antithyroid drugs. And there may be other reasons. And those are the cases who just can be managed with beta blockers, and they may be just thyroiditis. So how do you actually investigate? Because we have talked about that we do a blood checkup. We do a T3, T4 and a TSH. But along with that, do you do other tests? Do you do some scans? So how do you investigate these patients before you arrive at a diagnosis?
Thanks, Paramila, for another very pertinent clinical and practical point. And I think I personally think most of the people who we are not diagnosing because of multiple reasons, and one of the biggest reason is when you look at screening tests for thyroid disease, it's actually the cost of thyroid screening that we usually do in someone who even don't have a clinical suspicion. The cost of that actually hinders us in most of the physician ordering those tests. And I think that question that you're asking is very pertinent. I think the simple test which would start with the screening of a test is a simple thyroid stimulation hormone, which is a TSH. That should help you decide either you would want to go in the workup of a goiter, which is in the form, if you're euthyroid, you should go for an ultrasound. If your TSH is suppressed, then you have two options. And again, and I think that also depends on which region you are in. If you're very comfortable with your radiologist picking up the diagnosis, probably you can do an ultrasound as well. But in our clinical practice, in our regions, the ultrasound is so user dependent that a thyroid scan is probably the best way to diagnose between one or the other. And we've discussed the thyrotoxicosis versus hypothyroidism. Hypothyroidism is when thyroid is working more. Thyrotoxicosis is just extra thyroid in your hormone. So thyroiditis might not even need treatment. And again, as you rightly pointed out, if we don't have a thyroid scan done before we start the treatment, we get into two troubles. Number one, we don't have a diagnosis. So probably what you need to do is guess that person had a thyroiditis versus hyperthyroidism. The second problem is, even when you see a patient who's already started on medication, you cannot do much, because the thyroid scan cannot be done unless you stop the medication for 6 to 7 days and then do the thyroid scan to get the better results. And sometimes the patient is not in the condition that we can stop the medication at that time. It was happened right at the time that you should have done a scanning. So to answer your question, probably the best way to diagnose a hyperthyroid state is to look at your thyroid scan, doing a thyroid scan, finding out if it's a thyroiditis, hyperthyroidism, toxic nodule, or any other condition that you're thinking of. So that probably gives you the right answer, right time, one picture. Other modalities which can be used could be a blood test, which could be a thyroid TRAB, which is anti-TSH receptor antibodies, which can help you in one way or the other. I don't find a lot of benefit in doing a TPO or anti-thyroglobulin antibodies in a hyperthyroid patient, because they probably are not going to give you the answer of which condition are they. So thyroid scan, number one. Ultrasound, if you know the radiologist and you can trust the radiologist. Antibodies in the blood, if you don't have any other option, that's the option you can go for. And obviously, don't order too many tests at the same time. Please do not order thyroid scan, ultrasound, all the antibodies when you see someone who has a low TSH. Over to you.
Absolutely, because this is a very important point, that we should not do too many tests. And mostly in our country, we definitely go with the technetium 99 scan. And the other reason for doing that is also, like, even if you have a Graves with ophthalmopathy, we do it to rule out any presence of cold nodules, because many of these patients might be having some cold nodules which may warrant further investigation. So as you rightly said, I think most of the places we are doing this very same thing. Dr. Sharmeen or Dr. Prasad, do you want to tell that in your country if you do anything different, or Dr. Sara, if you do anything different?
I think we don't have uniformly uptake scans available all across the board. So,
Right.
but usually in my practice, I usually, as Abbas said, try to do a uptake scan so that you are having an exact diagnosis, particularly if you don't have fluoride eye signs and so on, where it is very obvious that you are dealing with Graves, in which case it may be a bit of an academic exercise to do an uptake scan. So otherwise, actually, I tend to get an uptake scan, which will tell us whether it is, Hashimotoxicosis or Graves, because sometimes in our part of the world, maybe it may be common because we see a lot of nodular thyroids with Graves. So it might be, useful to be quite sure what you are dealing with. Then coming to the ultrasound, actually, again, particularly at some point before I send the patient to radioactive iodine, I will definitely do a ultrasound scan, because I have seen, although according to the textbook and our teaching, malignancy is quite, not common in thyrotoxicosis compared to hypo or euthyroidism. I have come across a couple of, cancers, so I don't want to take any chances. Before you send the patient for radioactive iodine therapy, I will definitely do ultrasound scan.
Absolutely. That is a very, very important and a pertinent question, because many times we have experiences, all of us, I think, would have that experience in our practice, that we might not have had a palpable nodule, but when you do an ultrasound, you find some nodule which is highly suspicious, and it may not be a very big nodule. I had a patient who just had a 9mm nodule, but it was actually labeled as TIRADS 5, and that actually turned out to be papillary C of thyroid. So sometimes we may get surprises, but I agree with you that we cannot do it for every patient. It is on a case-to-case basis, we have to decide, because we are the primary consultant. We have to see which patient needs what sort of investigations and to what extent we have to go. So that is also very important, because we cannot over-investigate also. That also is going to be not good for the patient and may add to more of the cost.
But
So,
just one thought,
please,
I think
please.
getting ultrasound might be a must before you send the patient.
Yes, absolutely. That's a usual routine. We all go for, I always do an ultrasound scan before I send my patients for radioiodine, and that's a routine. I think if anybody would like to opine on that, Dr. Jabbar, would you like to please comment on that? So if anybody would like to opine on that, or their views on doing an ultrasound, because, yeah, please, Dr. Sharmin, please.
In my country, what we do in case of thyrotoxic patient, we first go for the thyroid function test, that is TSH and FT4. And when the TSH is suppressed, then what we do if the patient has got classic manifestation of Graves' disease, that is the typical eye sign and the soft goiter with severe toxicity, then we do not usually require further investigations. We can straight away start the treatment. But in all other cases, what we do, we advise a thyroid scan and radioiodine uptake. However, the scan and radioiodine uptake is not available all throughout the country. So in most of the cases, we go for thyroid scan. And as Dr. Abbas Raza said, I think preferably this is the most important investigation in differentiating the causes of thyrotoxicosis, and that will guide us to the treatment. However, we don't usually advise ultrasonography in hyperthyroid patients. We go for thyroid function test, thyroid scan, and thyroid uptake.
Absolutely. That's the usual way of practice. But yes, what we were discussing is like when we are going for a radioiodine ablation for that patient, and suppose we have decided to ablate, we do ultrasound to just see if there is any nodule which is there, which is suspicious. And that is the next step ahead if we are planning to go for an ablation for a particular patient. So carrying, Dr. Sara, would you like to comment, or should we go with the next set of questions?
Thank you for the question. There are many issues in that, but as per even UGOGO guidelines, it's that the ultrasound should be done, and if nodules, we should go for uptake scan. But however, there are many logistic issues, like also ultrasound is operator dependent many times. Many people, they want to go for the scan. And also I want to add one very important point, as there is latest publication about the GRADE score. So if we do the thyroid receptor antibody prior to treatment and at the end of the treatment, so the levels can also help us predict which patients are going to go into remission. So offering the choice of the basket approach, like at the outset, some patients may prefer going for the definitive therapy as the practice in many countries.
Absolutely. We also do in our practice that we do the thyroid stimulating receptor antibody before we stop the antithyroid drugs. We do it to check, because we know that this patient who has a higher level has a higher chance of relapse. So those patients might be continued maybe on a low dose and maybe given the option of further definitive therapy, as compared to those patients who don't have these levels higher or have almost negligible levels. So that is a definite thing, which is a very great usefulness of the TSH receptor antibody. So Dr. Sharmeen, will you like to comment that, like when you talk about adults, we know that there are so many manifestations. We discussed about cardiac, bone, and different things. But how do children present? Like, what do you see? Do they present something different? Like we were discussing, Dr. Sara pointed out that they can present like ADHD and different manifestations. But what are the other ways you see? Do they present like just weight loss, or do they present with some other features as well? Dr. Sharmeen, you're muted. Can you please unmute yourself? Yeah.
Thank you.
Yeah.
I think it requires a high index of clinical suspicion to diagnose hyperthyroidism or thyrotoxicosis in children, because the signs symptoms can be very subtle at times. If we divide this group into the very young children, that is the neonate and the infants, and the toddlers and the adolescents, the neonate can develop the neonatal thyrotoxicosis, which is due to transplacental transfer of the thyroid-stimulating immunoglobulin. This can be a medical emergency, and they can present with preterm labor, IUGR, microcephaly, exophthalmos, and multi-organ failure. So at times, the neonate has to be admitted to a neonatal ICU and treated likewise. And in case of older children, thyrotoxicosis is often underdiagnosed and misdiagnosed. Unlike the commonest cause in children is also Graves' disease, and toxic multinodular goiter and toxic adenoma can also occur. However, unlike the Graves' disease in case of adults who have got diffuse soft goiter, the goiter in children is often small and firm. The eye sign and the skin signs are often absent, and the signs of sympathetic overactivity, they are often very subtle. They might present with attention deficit hyperactivity disorder, and the parents often complain that they are absent-minded at school and they perform poorly in school. And when the thyrotoxicosis is severe, they may complain of tall stature, that is acceleration of the bone age and the age of the children when it is plotted in the growth chart. And pubertal problems may also arise along with some behavioral problem. The classic signs of sympathetic overactivity, like excessive sweating and weight loss, sometimes they might also be present in case of children. So I think it needs an astute physician to diagnose hyperthyroidism in case of children.
Yeah,
cardiac
absolutely.
manifestations may also occur at time, like heart failure
Yeah.
or atrial fibrillation.
Absolutely. So we can have different other little bit varied presentations and in children, and that can be sometimes difficult to pick up. So Dr. Sara, do you investigate the children like we discussed for adults, or do you do some other set of tests, or do you have a different approach for them, or do you follow them up? Like when we know that the long-term follow-up is required for children longer, and they may require a longer duration of antithyroid drugs. So how do you actually approach the children when they come to you with thyrotoxicosis? They may still be thyroiditis. We do see some thyroiditis in adolescent age groups, but mostly when the young children are coming, we do see Graves most commonly. So how do you actually go ahead with that?
Yes, thank you for the question. As already you mentioned that the most common cause of thyrotoxicosis in children is due to Graves' disease. So basics of the adult and the children, the investigations are similar, but an important difference is that the children, they have more overt and severe form requiring longer therapy. That is one. The basic is same, like biochemistry, serology, and thyroid imaging. So in biochemistry, we do similarly FT3, FT4, and TSH. Serology, we do TSH receptor antibody. And thyroid imaging is ultrasound is more preferable, especially in children, because of the concern for radiation uptake. If there is a definite nodule on ultrasound, then a thyroid scan may be considered, but otherwise it can be omitted. and the anti-thyroid drug management is the preferred in the children, but they require longer duration, and they have poorer outcomes as compared to other adults, and they have more chance of adverse effects. So these are the things we need to be aware of at the outset while managing children. Then the other differential in children can be McCune-Albright syndrome, which is an important differential. And of course, if suspicion of thyroiditis like pain in thyroid region is there, then ESR and CRP investigations can be added. Then, of course, if any signs of headache or on the biochemical findings are there, then TSHOMA or other rare differential are there, or some familiar causes are there. They are, of course, we have to investigate accordingly. But the most common is Graves' disease in children.
Absolutely, absolutely agreed, because this is a very important point. And now we come to the final part of it, because we have this last 10 minutes of our panel where we have to discuss about the various treatment modalities. We've already discussed about anti-thyroid drugs, and we know that there are two other options of radioiodine and surgery. Though we know that if you talk about the third option of surgery is almost very rare. And even today I was talking to my surgeon, and she was telling that in the past 10 to 15 years, they are hardly operating the hyperthyroidism patients. So I would like to hear from all the panelists, because all of you are from different countries. How do you practice, and what is your approach? When do you go for radioiodine ablation? Do you go for all people above 40, or do you wait till 18 months and then go? And what do you do for pregnancy or women who are planning for children? Because a lot of time the women are planning in the reproductive age group, but they are not planning for a child for a year. So do you suggest radioiodine, or do you go for other options? So we can start with Dr. Prasad, like in your country, how do you do that? And then we can come to Dr. Abbas, and then to Dr. Sharmeen and Sarah, and then to Dr. Pratosh, because he's from our country. So we know the practices, but we want to hear from you.
Actually, we nowadays don't very strictly adhere to this 18-month rule. So we usually go by the clinical sort of, behavior. Usually somebody who would anyway needs, very high dose of antithyroid drugs after even about, 3 to 6 months after starting treatment, most of the time, they might need a definitive treatment. So what we would do is then we'll consider the other circumstances, whether they are socially able to, some people might not be able to socially have radioactive iodine treatment or even surgery because of the having small kids, family commitments, educational commitments, and all these things, and then decide what to do. And then again, the other things that you would consider, as you say, the fertility and pregnancy wishes, where somebody already quite old and not having children, but they have only very short time span to complete the family. So that sort of people, we might generally encourage them to have surgery. Or else if they have very large goiters, which might anyway need surgery in the the time to come for cosmetic reasons and the other reasons. And then otherwise we might, if they are quite young and then they have time to postpone pregnancy and so on, and then don't have very large goiters, we might encourage them to have radioactive iodine. Another thing that I had noticed is, again, if they have very large goiters and then also need very high doses of antithyroid drug, the relapse rate or the not going to remission, failure rate of radioactive iodine therapy is quite high. So these all will be taken into account on deciding when and what treatment that we would offer for definitive therapy.
I also welcome comments from Dr. Shashank. He is our president-elect of the Indian Thyroid Society, and Dr. P.K. Jabbar. He is our president-elect of the Endocrine Society of India. So Dr. Shashank and Dr. Jabbar, please, your comments, please, on this topic, please.
So Dr. Pramila, I completely agree with what your comments are. Surgical option has virtually become extinct. and it is restricted between medical options, and iodine therapy also is restrictive. So that would be my short comment, but I agree with all the panel members.
Thank
Jabbar?
you, sir.
Hello,
Yeah,
Pramila.
Dr. Jabbar, we can hear you. Yeah.
Pramila, I did not get the question.
We are discussing the question that versus the antithyroid drugs, the option of radioiodine therapy and surgery. So we are discussing in different countries, what is their practice approach?
No, it's in our opinion is very simple. And so myself and Shashank Joshi, we are coming from same institution. So we used to go for medical treatment also, but I think there are sufficient data to give antithyroid drug as a drug of choice. Even the prolonged drug treatment is very well acceptable. And our experience from KM hospital also we were very happy with the antithyroid drugs. Okay, we of course after recurrence will change our strategy. That's our policy, usual policy from KM. Okay, surgery for limited cases. Of course, nowadays radioactive iodine treatment is freely available in Kerala state. In our place, and 2 centers are there. So we used to give radioactive iodine, not for all cases, probably with the recurrence only we are giving. That's our usual practice now. Okay.
Yeah, thank you. Dr. Syed, your comments, please. In your country, what do you do?
Pramila, I'm trained in US, and I'll start with a quick survey which was done way back about 15, 20 years ago among the endocrinologists on each side of Atlantic. So there were American endocrinologists and there were European endocrinologists, and surveys was done. And I think there's never in medicine, as you can, all the options are valid, and any one of your patient could be rated to that. But it was a very clear demarcation between about 20 years ago or 18 years ago. Most of the people on the American continent said that they would want to treat people for it as soon as with the antithyroid, as soon as they become euthyroid, they will treat it with radioactive iodine for the definitive diagnosis. While the people on the European side, endocrinologists on the European side, said that we will treat them for at least 18 months and again then treat them with radioactive iodine. I think most of us in this part of the world, including myself, practice a little different than what we used to. So I think anti-thyroid antibodies play a major role as well at this time. So if you're starting someone on anti-thyroid just to make them euthyroid, and if their antibodies turned out to be negative after certain months of treatment, probably these are the people you could give a trial of oral medication and maybe try to taper off and see if they remain in remission. While the people with a high antibody titer, which is persistent even when they are taking medication for a few months, may be a better candidate for sending them for a radioactive iodine. So I think antibody, although you can treat them, you can take any protocol and there's data to support on either side of it. But I think we need to plug in and throw in antibodies, titers and antibodies as well to decide if we want to continue with the oral medication or if we want to give the radioactive iodine.
Absolutely. So Dr. Sharmeen and Dr. Sara, your point of view, please. And then we can go to just the closing remarks because we are nearing the last part of the panel. Yeah, Dr. Sara, please.
Now, sir, I'm practicing right now in Dubai. So Dubai is like healthcare is primarily insurance based. So we start with primarily antithyroid drug therapy and first treat for 18 months at least. And there are certain patients who are on long-term, even low-dose antithyroid drugs because the radioiodine ablation is like not covered for every patient, or some insurance issues are also there. So, and majority of patients, they respond well to antithyroid drugs. So that is the primary approach. And of course, the thyroidectomy option is very rarely being used actually. So
I fully agree. So that surgery options are almost very less unless there are absolute indications. And we also do use long-term antithyroid drugs with a very low dose. And a lot of our patients are on long-term antithyroid drugs with a very low dose and they do well. And this is how most of the, I think in all the countries, almost the practice is almost the same with little bit differences. Dr. Sharmeen, in your country, what do you do? And especially for children, if you would like to make a comment, what do you do for children, like for radioiodine? At what age do you go for radioiodine? And when do you decide to radioablate a child? Because for children, we know that we do use radioiodine ablation, but when in your, at what age do you prefer in your country and when do you go for it?
Okay. What we do in our country is that anti-thyroid drugs are still very popular, but radioiodine therapy is becoming popular day by day. And radioiodine therapy is very cheap, and it is available in almost all government medical college in our country. So that when the patient is non-compliant, has got hypersensitivity reaction or something like that, in relapsed and persistent cases, we offer radioiodine. For children, we rarely use radioiodine. We tend to use anti-thyroid medication for most of the children. However, if the children is non-compliant or there is agranulocytosis or other hypersensitivity reaction, or in case of relapse, as the indications are in adult, we use radioiodine in case of children. However, these are limited to very few cases, and we tend to avoid these cases in very young children till the age of 15 to 17 years of age.
Thank you. So Dr. Pratosh, there are a few questions from the audience if you would like to take that. So audience is asking, can anti-thyroid drug induced liver dysfunction occur after 2 years of initiation of therapy? So they are asking, can it be an idiosyncratic reaction?
Generally, the data says that 6 months, almost 100% of the hepatocellular dysfunction happens with anti-thyroid drugs. And current recommendation says that if you have no adverse event after 6 months, the risk is very, very less and it's negligible. So
Yeah,
that is
but it can still happen. We cannot
it can
say
happen.
no for it, but
we cannot say no,
uncommon.
absolutely no.
Yeah.
It's very, 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 very rare. Yeah.
And one more question is there for you. So the question is that when a patient is on carbimazole, becomes hypothyroid, so they are asking, should we lower the dose or should we add a levothyroxine supplement simultaneously? That is one of the questions, if you can take that.
Yeah, it's a tricky question. The block and replacement therapy is not the absolute block and replacement therapy. It is not actually recommended in the beginning because there is more adverse event associated, although efficacy is similar to the dose titration method. But here, what they ask is interim treatment when a scenario occurs. We can say it's a kind of partial block and replacement. Sometimes we do it because in a very fluctuating scenario, we start with low dose of levothyroxine and monitor closely, and then take away the levothyroxine and then continue the lower dose of antithyroid drug. This we often do in practice, but general dictum is to lower the dose and observe rather than adding levothyroxine.
Dr. Jabbar, your point on that, would you like to comment on this? Okay, his some sound issue is there. So, okay, we'll go ahead.
Yeah,
so Dr. Prasad, would you like to comment on that?
Sometimes, particularly, I don't think that it should be done by everybody, but particularly people who are very experienced, I think it might be quite a useful practice to not straight away upfront put the people on block and replacement therapy, but when you are titrating, some people are quite sensitive to the carbimazole, and then once you sort of they go into quite profound hypo, but then when you stop, then again they go into like seesawing, like go into peaks and troughs, and so what I do quite often in that scenario is to give a tapering dose of thyroxine, and then towards the latter part of the last week or so, they would not take any thyroxine. So you are fairly certain then if you do a free T4 also, you'll be able to nicely fine tune and see whether your dose of carbimazole is making the patient sort of control without pushing them into hypothyroid. So actually I use this quite often in titrating their carbimazole dose or the methimazole dose.
Yeah, so most of the times what we practice is we reduce the dose and we go with the reduced dose, and then we follow up, and the block replace is mostly not into practice now, but there are a few people who still practice it, though now the studies have not shown much usefulness of that, and we normally go with the reduction of the dose. But it's also a good point that when the patient is having frequent fluctuations, these are also the candidates for radioiodine ablation. These are not the best candidates for continuation of antithyroid drugs as well. So there are questions regarding subclinical hypothyroidism in pregnancy. I think that's not in the purview of the panel discussion because our President-elect, Dr. Shashank, will be discussing on a topic of subclinical hypothyroidism. So there we'll take up this question because that's a little bit out of the purview of this panel. So before we just end this panel, one take-home point from all the panelists and Madam also, and then we can close this panel. So Dr. Pratosh, we can start with you. One take-home point from the discussion we had today or for the audience.
One point is anti-thyroid drugs are really safe. We don't have to worry much about the adverse event. You should monitor closely and then decide the treatment. That's the take-home.
Thank you. Dr. Sara, your take-home?
My take-home is that it's always good to get a baseline complete done. Then it's easier to in the follow-up to see if somebody is having any adverse reaction.
Absolutely. Dr. Syed, your take-home?
Quick and sweet. You have all the tools in your armamentarium. Use them wisely. Select the tool which is necessary. Don't overuse them, but definitely don't underuse them as well.
Absolutely, well taken. Dr. Prasad, your take-home, please.
The patient education is quite important from the beginning. They should know what to expect, in the long run from the beginning. So otherwise they will be very blind and then the compliance would get affected.
Absolutely. Dr. Sharmin, your take home, please.
That modalities of treatment in hyperthyroidism should be chosen widely. Unnecessary surgery, which at times occur in the hand of ENT surgeon, I think it should be avoided. And there is no need to offer radioiodine therapy. It is relatively safe option and it is rather inexpensive and it is most effective. So we can offer it more frequently.
Saita ma'am, your closing remarks for the panel, please.
First, thank you to all the panelists for the wonderful discussion and Pramila for being a great moderator. Amongst the two, the most common amongst all thyroid diseases, of course, hypothyroidism is far, far more common, thankfully. And I think hypothyroidism is much easier to treat. Hyperthyroidism is, of course, it's not difficult to treat, but it is more of a sinister disease as compared. And I think I agree with Dr. Abbas that the tools one should select very carefully and continue to monitor the patient. Results are very rewarding for management of hyperthyroidism. Thank you.
So I thank all the panelists. We really had an excellent discussion. We could not touch few points like pregnancy and hyperthyroidism, but because we had a short time, so I thought this was a good way to at least give the message to the audience about the treatment of hyperthyroidism and differentiation from thyrotoxicosis, which is very, very important because many a times we see that patients who have subacute thyroiditis are being treated with antithyroid drugs. So there the TC99 scan, the TRAB antibodies, all these come handy, and obviously our clinical judgment. So I think with this, we end this panel and hand it back to the chairperson, Dr. Jabbar sir, and he can take over from here.
I think it was an excellent topic presentation. I think so. We should congratulate Dr. Pramila Kaldra for excellent management of the topic, and she moderated very well. Now we have few topic presentations also. I hope so Dr. Shashank is going to talk now. Am I right, Dr. Pramila?
Yes, sir. Yeah.
Okay. Yeah.
Ganvi, you can just.
We will have the quiz, ma'am.
So we have the quiz first and then the.
Okay, then
lecture.
I think so. Over to Ganvi.
But get the quiz first. After the quiz is the talk.
Yes,
yeah,
sir,
that's
yes.
fine.
Which
okay.
I have pre-recorded, and but I am around on the Zoom call.
Okay, that's fine. Okay, then Ganvi, please take over.
Yes, sir. So thank you, panelists and moderator, for a very gripping discussion. So now, before we go to the quiz, we will briefly go through the video of the ITSCON 2023, that is the annual conference of the Indian Thyroid Society. So I request the IT team to play. So now we will have the quiz by Dr. Arpit Garg. So prior to this, I request the IT team to display the quiz participation rules. So here are the quiz participation rules. To participate in the quiz, having a Zoom app on your mobile device or laptop is essential. You are requested to use a laptop for the ease of experience. The quiz will run for about 10 minutes. There will be first 2 dummy questions followed by the actual quiz. The quiz master will display the case or the description of the question by screen sharing a PowerPoint file. The participants should use the polls option to participate in the quiz. All 10 questions will be available when the poll is launched, and answer for all the questions is to be submitted at once at the end of 10 minutes. To read the case or description, you can use the polls using the X button and again use the polls option to answer the respective questions. So I now request Dr. Jabbar sir to introduce Dr. Arpit Garg and to start off with the quiz.
Ma'am, can I launch the dummy quiz poll?
Okay, sure.
May I, Ganavi?
Yes, sir. We shall have
Yeah.
2 dummy questions, sir. After that, you can introduce Dr. Arpit Garg, sir.
Okay.
So the dummy questions are number 1, in which city is Taj Mahal located? Option A, Chennai. Option B, Mumbai. Option C, Agra. Option D, Bangalore. The second question is, how many oceans are there? Option A, 8. Option B, 5. Option C, 6. And option D, 7. I hope all the participants could log in their answers. So now over to Jabbar sir for introducing Dr. Arpit Garg.
Dear friends, once again, I'm here. See, I would like to introduce my friend, Dr. Arpit Garg. He is currently practicing in Amar Hospital, Patiala. He is having a lot of the credentials, and he is one of the best students with the gold medal, and is one of the life member of Endocrine Society of India and American College of Clinical Endocrinologists, very active in academics and a regular speaker for most of the conferences. Let me introduce Dr. Arpit Garg for conducting the quiz competition. Over to Dr. Arpit, please.
Good evening, Jabbar sir, and good evening, everyone. And thanks a lot, Dr. Sarita ma'am, for inviting me on this platform to conduct the quiz. So I'm going to share my screen for the quiz. So coming to the first question, a 39-year-old woman is referred because of abnormal thyroid function tests. She has no overt clinical symptoms except a mild tachycardia and palpitations during exercise. Physical examination reveals a small goiter. Her thyroid function tests reveal a TSH concentration of 4.3 milliunits per liter and free T4 of 39 picomoles per liter. And previous samples 6 and 12 months ago had similar results. The options are option A, resistance to thyroid hormone. Option B, non-thyroidal illness. Option C, familial dysalbuminic hyperthyroxanemia. Option D, amiodarone. The time is complete for the first question. Now we come to the second question. What is the recommended concentration of iodine in iodized salt in India? Option A, 10 parts per million. Option B, 15 parts per million. Option C, 20 parts per million. Option D, 25 parts per million. The time starts now. The time is over. Now we come to the third question. Make the correct match. The images are shown here of various thyroid cancers. You have to match the options 1, 2, 3, 4 with the respective images. Option 1 is the papillary thyroid carcinoma. Option B, these are the name of the carcinoma. That is, 1 is mentioned for papillary thyroid carcinoma, 2 is follicular thyroid carcinoma, 3 is medullary thyroid carcinoma, and 4 is anaplastic thyroid carcinoma. And these images these are in Roman numbers. In the option, as we can see here, there are Roman numerals. So these images are in Roman numerals. First,
Sir,
second,
sorry to interrupt you, but your slides are not moving.
Yeah, that's what Arpit.
Just
Arpit,
yes, ma'am.
your slide is not moving.
Just
You
a
are
minute.
still in first slide.
Dr. Arpit, what you can do is you can stop sharing and share the full screen mode of your PowerPoint.
Yeah.
When you are selecting which screen to share, you can select the full screen mode.
I'll do that. Just a minute. Actually, is
Yeah,
it moving?
Yes, yes,
Now-
yes, yes.
Yeah. So I'll start it again then.
Yeah,
First-
now, yeah.
Yeah. A
I think
39-year-old woman.
faster for the first two questions. And then third one, I think you were on the third one, right?
Yes, ma'am.
Okay.
So
I think you go a
should I-
little faster for the first two, for the third one, because you have to match the photographs, right? Go ahead. Go ahead.
So I'll start from the third question now, ma'am.
No, you start with the first only, but I'm saying just go faster for the first two questions.
Yeah. A 39-year-old woman is referred because of abnormal thyroid function tests. She has no overt clinical symptoms except a mild tachycardia and palpitations during exercise. Physical examinations reveals a small goiter. Her thyroid function tests reveal a TSH concentration of 4.3 milliunits per liter and a free T4 of 39 picomole per liter. Previous samples 6 and 12 months ago had similar results. All of the following conditions explain these thyroid function tests except option A, resistance to thyroid hormone, option B, non-thyroidal illness, option C, familial dysalbuminemic hyperthyroxanemia, and option D, amiodarone. So the time starts now. Yeah. Now we come to the second question. What is the recommended concentration of iodine in iodized salt in India? Option A, 10 parts per million. Option B, 15 parts per million. Option C, 20 parts per million. And option D, 25 parts per million. Now we move to the next question. Make the correct match. So we have here 4 carcinomas are shown here: papillary thyroid carcinoma, follicular thyroid carcinoma, medullary thyroid carcinoma, and anaplastic thyroid carcinoma. And 4 histopathologic images are shown. You have to make the correct match. The time starts now. We move on to the next question. 6-year-old boy presents with weight gain, poor academic performance, and physical examination reveals goiter. His bone age is 7.8 years by Tanner Whitehouse RWS3, and TSH is 46, T3 0.7 nanograms per ml, T4 4.1 micrograms per ml. Anti-TPO antibodies are negative, and ultrasound revealed diffuse goiter with increased vascularity. Radioiodine uptake scan showed more than 50% uptake at 30 minutes and 5% uptake at 24 hours. Which investigation would be diagnostic in this case? Perchlorate discharge test, saliva to plasma iodine 125 ratio, urine monoiodotyrosine and diiodotyrosine measurement. Option D, DOX2 gene analysis. The time starts now. Coming to the next question. 42 years old gentleman, known case of Graves' disease, presented with swelling both eyes. All of the following agents have been tried in the treatment of this condition except anti-TNF agents, anti-IL-6 receptor antibody, anti-IL-1 receptor antagonist, anti-CD20 monoclonal antibody. The time starts now. Coming to the next question. 58 years old lady presented with Thyroid's 4 thyroid nodule. FNAC revealed papillary thyroid carcinoma. On imaging, it was a local disease without any metastasis. Total thyroidectomy was performed. Stimulated whole body scan at 6 months showed uptake in the thyroid bed, and stimulated thyroglobulin was 120 nanograms per ml. Patient was administered radioiodine therapy. At 1 year, stimulated whole body scan was normal. Stimulated thyroglobulin was 200 nanograms per ml, and PET CT scan was done, which revealed this. What would be the most appropriate management for this patient? Option A, re-administer high-dose iodine 131, cabozantinib, lenvatinib, or radiotherapy. The time starts now. Moving on to the next question. 42 years old gentleman is on amiodarone for the past 18 months for intermittent ventricular tachycardia. He presents with fatigue, weight loss, and tremors. On examination, there was a firm neck swelling with multiple nodules. Which of the following biochemical scenario is most likely? Option A, low TSH, high FT4 and very high FT3. Option B, low TSH, very high FT4 and very high FT3. Option C, low TSH, high FT4 and FT3 in the high normal range. Option D, TSH low normal, FT4 high normal and very high FT3. The time starts now. Moving on to the next question. 22 years old boy, known case of Graves' disease with thyroid associated ophthalmopathy, presents with pain and redness in eyes. On examination, the clinical activity score is 6/10 and there was a moderate disease. MRI orbits was done. Which MRI image is most likely? 4 MRI images are shown here and you have to select the appropriate MRI image which is most likely for this patient. The time starts now. Moving on to the next question. 7 years old girl presents with vaginal bleeding. There is history of poor height gain and excessive weight gain. On examination, there is no thylarch or pubarch. Bone age is 5 years by TWROS 3. LH is less than 0.5, FSH 2.4, prolactin 122 nanograms per ml, TSH 146 milli-international units per liter, T3 less than 0.5 nanograms per ml, and T4 less than 3 micrograms per ml. Which of the following statement is false regarding her condition? Option A, called as Van Wyck-Grumbach syndrome. Option B, due to TSH cross-reactivity with gonadotropin receptors. Option C, can present with heterosexual precocity also. Option D, treatment with LT4 replacement alone is needed. The time starts now. Moving on to the next question. Which of the following statement is true regarding the timing of prophylactic total thyroidectomy in MEN2 patients? Option A, RET M918T mutation, total thyroidectomy at or before 2 years of age. Option B, RET C609F mutation, total thyroidectomy before 10 years of age. Option C, RET C634F mutation, total thyroidectomy at or before 5 years of age. Option D, RET C620F mutation, total thyroidectomy within 6 months of age. The time starts now. I think this was the last question. Thank you. Thanks a lot. Over to Dr. Ganvi for taking the session forward.
Thank you, sir, for a very compelling quiz. So moving on, now we have a pre-recorded video of Dr. Shashank Joshi, sir, on subclinical hypothyroidism, when to treat. But before we go on to this, I would request Dr. Jabbar, sir, to give a brief introduction about Dr. Shashank Joshi, sir.
Good evening, my dear friends, Dr. Sarita Bajaj, esteemed members. It's my pleasant privilege to introduce my own friend, my classmate, Dr. Shashank Joshi. I think it is superfluous to discuss or introduce Dr. Shashank Joshi to this crowd. He is a very eminent teacher, orator, clinician, good organizer, and moreover, a person with a very soft heart. I don't want to discuss it again and again, because if I'm introducing Shashank Joshi again and again, I have to take minimum 25 minutes. So, over to Shashank Joshi for delivering your speech. Shashank Joshi, please.
I request
Technical team.
Yes, ma'am.
I think it's a recorded program, please, you can.
So at the onset, I want to wish everybody a very educative World Thyroid Day. We are here to help our people living with thyroid diseases. I must thank at the onset our Indian Thyroid Society for taking this initiative. Our president, our Didi, Dr. Sarita Bajaj, Secretary Dr. Arun, and all the organizers of this meeting, including Dr. Pramila. Today I'm just going to talk on subclinical hypothyroidism. We were discussing hyperthyroidism and when to treat. So it's something which we need to know. What are the criteria for subclinical hypothyroidism? Is there any classification, etiopathogenesis? When does the clock tick to progress to hypothyroidism? Is there a genuine cardiovascular risk? In the geriatric population of senior citizens, should we treat everybody? Is there an overall consensus on treatment of or management of subclinical hypothyroidism? And what are the current guidelines saying? And maybe a simple take-home message. So clearly we know if the TSH is above 4.5 with a normal free T3, free T4 or T3, T4, without any symptoms or signs of thyroid disease, it is subclinical hypothyroidism. But technically, when the T3, T4 is normal, there are two categories. One is a markedly elevated TSH about 10, and the other one is between 4.5 and 10. About 10, the data to treat is compelling. The controversy all comes between the normative data and above normative data between 4.5 or 4, whichever reference range of the lab you measure, and 10. So clearly we recognize that the pituitary TSH rises first and the T3, T4 declines later, and we all know this very well. And we know that the predominant cause of it is autoimmune thyroiditis or Hashimoto's. We also know often the subclinical hypo patients are asymptomatic, and the non-specific complaints like fatigue, weakness, weight gain, cold intolerance, constipation can be seen in many other conditions. But it's important to recognize that in mild chronic thyroid failure, there are transient causes of increased TSH. So they need to be ruled out. For example, if you are recovering from a non-thyroid illness as simple as acute flu or like a COVID, on any recovery from thyroiditis, medications like amiodarone or lithium, lack of adherence to treatment of thyroxine, or the persistent increase can be seen as an aging phenomenon. You know that senior citizens can have a high TSH of 6 or 5 or 4 for that local geography, for that local topography, and if it's iodine insufficient region, or maybe it's a heterophile antibody in the assay, or maybe the person is very obese, or very rarely it could be an adrenal insufficiency, or very, very rarely it could be a thyroid hormone resistance. So typically the dysfunction progresses to overt hypothyroidism at the rate of 2 to 6%. That data is not very clear cut. Its likelihood of progression is more in women with higher the TSH and when there is presence of autoimmunity with anti-TPO antibodies. So clearly, the primary challenge of high TSH, particularly between the age 35 and 70, is the cardiac outcomes. And we all know that when there is subclinical or overt hypothyroidism, the peripheral action of thyroid hormone is blunted and the intracellular calcium handling is altered, and therefore the myocardial relaxation is slow, and therefore you get impaired LV diastolic filling. So the results of systolic dysfunction are not clear-cut, but the diastolic filling are clear-cut. So there is a lucitropic defect which is seen. If you look at all the data published, and this is more than a decade old, various studies have shown that the subclinical hypo has been associated with risk of fatal, non-fatal cardiovascular events. And the age tertile there particularly has been between 35 and 70. And similarly, if the TSH is high, there is also a risk of cardiac failure. This is from prospective circulation cohorts. And there is an outcome of cardiac failure, whether it's cardiac events or all-cause mortality is more. And various studies have shown there is also a link between dyslipidemia and subclinical hypothyroidism. And also there is a linkage between carotid intima medial thickness, metabolic parameters, especially whether you treat or you don't treat with subclinical hypothyroidism. Overall, there is a small but statistical increase in mortality in people living with subclinical hypothyroidism. So if you don't treat subclinical hypo at all, leave it alone, what could be the outcomes? One could be hypertension, cardiovascular abnormalities, endothelial dysfunction, stiffer arteries, and dyslipidemias. And eventually it could lead to increased cardiovascular morbidity and mortality. Is a hypothesis. Is it validated? We don't know. But unfortunately, in the senior citizen population, so somebody is above 65 and 70, the actual normal curve of TSH shifts to the right, and therefore it may not be inappropriate to treat them. So obviously with age, there is a change, and the TSH increase, which is age related, there is a change in the TSH set point, or there is a reduced TSH bioactivity rather than occult thyroid disease. So in senior citizens or geriatric population, particularly older they get, if there is only a borderline TSH, it is likely to be a situation of not occult thyroid disease, but an altered TSH set point or a reduced TSH bioactivity. So in the older adults, when you give thyroxine for subclinical hypo, and when you look at this NEGM trial, clearly it concludes that there is no benefit. So this was a trust trial funded by the European Union and clearly showed that if you treat senior citizens in subclinical hypothyroidism, you don't get any tangible benefits. So the question asked, which is why I'm talking, is in subclinical hypo, should we treat or should we not treat? There are two paths, and let us look at that. So when we look at data, in new onset subclinical hypothyroidism patients from UK, GP base, people above 40, TSH between 5 and 10, with a normal free T4, they excluded all other diseases which are prevalent. Between 40 and 70, the likelihood if you treat of cardiovascular events is lower, and the hazard ratio is 0.62. So it's important that in the middle age group, between 35 and 70, if you treat a abnormal TSH value, maybe there is a positive trend towards a cardiovascular outcome. And also from the mortality standpoint, between 40 and 70 years, you can again see a hazard ratio of 0.36. This is published data almost a decade and a year back, 11 years back, to show that thyroxine treatment decreases mortality between 40 and 70. However, if it is above 70, there's increased cardiovascular outcome. So, you know, if you are bordering towards senior citizen, geriatric age group, it is better not to treat. And that's something which we need to recognize. And similar data for mortality also exists. When you look at RCTs on dyslipidemia, so that was on the cardiovascular standpoint. When you look at dyslipidemias, whether you treat or whether you don't treat, and when you do an RCT, usually with mild TSH increase, the thyroxine therapy is beneficial on the lipid standpoint. So in non-pregnant adults, if the TSH is about 10, I don't think there is any doubt in anybody's mind, because there is a data to suggest that a subclinical hypo about TSH 10 is linked to atherosclerosis MI, and there's a progression to overt hypothyroidism even in asymptomatic patients, and therefore should be treated. So whether any association you will see, and below 10, when do you treat? Goiter, antibody, TSH is continuously 2 consecutive values above 8, persistent rise of TSH, younger patient, people with diabetes, dyslipidemia, pregnancy intended or pregnant patient, infertile, ovulatory dysfunction, and sometimes occasionally even we give a therapeutic trial. And therefore it's important to recognize that you segregate patients above 65 and below 65. And if they are below 65 with symptoms of hypo, positive antibodies, rapidly rising TSH, pregnancy being planned, large goiters, diffuse, probably intent is to treat. If there's a, if you treat above 7 TSH, the likelihood of fatal stroke and coronary artery disease mortality is less if the patient is below 65 years old. And obviously, in above 65, if the TSH is above 7 to 9.9, probably you may treat, but it's something may. Above 10, whether independent of age, the likelihood of progression to heart failure, hypothyroidism, cardiovascular events, and mortality is high, and therefore it is prudent to treat. So if you look at the ITS guidelines, they're very, very simple and straightforward. They're all linked to the TSH of 70 above and below. And if you look at the global guidelines, whether it is the European guidelines, the American guidelines, the Indian guidelines, the prudent answer is younger patients treat, older patients conserve, and that is a simple answer which I want to give, and we can have a dialogue and discussion. Treated with thyroxine, people without cardiac disease or with cardiac disease, start low with 12.5 or 25. Without cardiac disease, go to 1.7 microgram per kg body weight. And even in senior citizens, start with the lowest possible dose. That's the dictum. So I am very clear in my message that we all know that thyroid hormones regulate our cardiovascular system to meet the body's energy consumption. If there is a subclinical hypothyroid situation, it leads to alterations in cardiac contractility, vascular function, lipid and lipoprotein metabolism. And whenever we give thyroxine, particularly in the age group of 40 or 35 and 65 or 40 and 70, the likelihood of cardiovascular and mortality data is compelling based on RCT evidence as well as case control evidence. So in that it matters. But in the senior citizens or the elderly population, the data is conflicting and it is better not to treat. So obviously we need to individualize cases and we need to manage it. Most guidance is recommended based on these suggestions and guidance. Thank you for a patient hearing. And I'm certain that we will be able to do some dialogue and discussion. And again, I'm grateful to the Indian Thyroid Society for allowing me to make a quick dialogue based on slides. And I'm certain that we'll be able to do a much better dialogue when we get into a discussion mode, so that I can answer all the individual queries you have. But the data is very, very clear cut that TSH, treat or not to treat, if it's asymptomatic or subclinical hypo, is an individualized decision based on the patient phenotyping and based on the various other parameters which I told you, like simple antibody positivity, presence of goiters, underlying dyslipidemia, cardiometabolic conditions, as well as the age. And this all decides whether we should treat. And sometimes in the younger population, it is prudent to treat. In the senior citizens, probably a wait and watch policy may be that of order. If the TS is about 10, the likelihood is that we go easy. And if you're handling a senior citizen, we use the lowest possible dose. If you are having an underlying cardiac abnormality, we use the lowest possible dose and then gradually up titrate. Thank you so much for a patient.
I think you can. Ready? Okay. Thank you very much, Professor Shashank Joshi, for the lucid, very clear-cut messages he has given. I think, I need not brief the take-home messages again. Once again, I want to congratulate Dr. Shashank Joshi for the excellent presentation. And you can, I think he'll be very happy to answer a few questions also. Ganabi, any questions in the chat box?
Sir, it is from the previous case, from the previous panel discussion only there are questions. Now there is a question, sir. If the TSH is more than 10,
suppose 40 with normal T4, can fitness for, I think Shashank Joshi is a common issue. See, if the patient has got a minimally elevated TSH to a tone of 14 or 15, what would be your stand for giving fitness for surgery, major surgery? Over to Shashank Joshi, sir.
So if it is an emergency surgery, there is no need to thyroid to be a barrier for this. If it is an elective surgery, then we can defer it or sometimes just give a start thyroxine and give fitness. But the main thing is you have to monitor, cardiac monitoring has to be done. So there are three things for surgical fitness. Number one, whether it is elective or emergency. Number two, the underlying cardiac disease. And number three, the nature of surgery and nature of anesthesia. So if it is local, regional, or spinal, usually there is no major contraindication. If it is general anesthesia or a major surgery above the diaphragm or below the diaphragm, then one may defer the surgery and have adequate thyroxinization.
I think the message is very clear enough for this type of cases. Definitely you can go ahead with the surgery. That's a take-home message. Any other questions, Ganavi, in the chat box?
No, sir, I cannot see any
That's
more.
all.
Yes.
I think, it was very clear, crisp, and messages were very, very super messages. I think, we'll close the session now. And I want to congratulate Shashank Bhai again and again for the wonderful presentation. And this session is closed, and the session are handed over to Dr. Ganavi for conducting the procedures again.
Yes, thank
Ganavi?
you, sir.
Yeah.
Yes, sir. I now request Dr. Arpit Garg, sir, to discuss the answer for the quiz conducted yesterday as well as today. So over to Arpit Garg, sir, to discuss the answers and then to announce the quiz winners.
Thank you, ma'am, for inviting me again to the session. I'm going to share my screen. Just a minute. First, I think, should we discuss the yesterday's quiz questions?
So we can discuss today's and then we can discuss.
Okay.
Today and then yesterday. Okay, the other way around.
So the first question was a 39-year-old woman referred because of abnormal thyroid function tests. She has no overt clinical symptoms except a mild tachycardia and palpitations during exercise. Physical examination revealed small goiter. Thyroid function test revealed TSH concentration of 4.3, which is normal, and free T4 concentration of 39 picomoles per liter, which is high, as the reference ranges are shown here. And previous samples 6 and 12 months ago had similar results. So this patient has, if you can see here, this is a case of hyperthyroidism, but no overt clinical symptoms except mild tachycardia and palpitations. If we see the options here, resistance to thyroid hormone, non-thyroidal illness, familial dysalbuminic hyperthyroxemia, and amiodarone, out of these three, option A, C, and D, that is resistance to thyroid hormone, familial dysalbuminic hyperthyroxemia, and amiodarone, all these three conditions can present with mild hyperthyroidism, but the non-thyroidal illness never presents with hyperthyroidism. Rather, non-thyroidal illness typically presents with low T3 syndrome. Stages, it can present with low T4 also, along with low T3. But there is never elevated free 3 or elevated free T4 concentrations found in non-thyroidal illness. And that's why the non-thyroidal illness is the correct answer for this question. Coming to the next question, what is the recommended concentration of iodine in iodized salt in India? Option A, 10 parts per million, option B, 15 ppm, option C, 20 ppm, and option D, 25 ppm. The correct answer is option B, that is 15 parts per million. The government of India has mandated that, it has recommended that the iodized salt should contain 15 parts per million of iodine. And this is a recommendation from FSSAI. Coming to the next question, to make the correct match. So 4 images are there, image 1, 2, 3, and 4. If we can see here, the image 1, it is of the papillary thyroid carcinoma. As we can see here, the semoma bodies which are present in the interstitium. And we all know that semoma bodies are characteristic of papillary thyroid carcinoma. And there is papillary, in this image, one semoma body is visible here, which I'll point out with the pointer, just a minute. Yeah. So semoma body are visible here, one small hair and one big hair, and there is papilla formation. Coming to the option, second image. Second image is of the medullary thyroid carcinoma. If you can see here, this is a normal thyroid follicles, normal gland part is there, and this is the abnormal gland part. The thing which is showing here, which is making it is a papillary thyroid carcinoma, is the presence of hyaline in the interstitium. So hyaline is present in the interstitium. If we can see here, this is the interstitium, and small hyaline deposits can be seen here in this, which are highlighted by red. Coming to the third image, it is of follicular thyroid carcinoma, because if we see here, there is invasion of the vessels by the cancer or the thyroid cells, tumor cells. And the characteristic of follicular thyroid carcinoma is vascular invasion. If vascular invasion is not there, it is very difficult to detect follicular thyroid carcinoma, and that's why it is usually diagnosed after thyroidectomy, because we have to see the thyroid tissue in whole. We have to see the capsule also and the vessels also. So on the basis of FNAC alone, it is very difficult to diagnose follicular thyroid carcinoma. It can be diagnosed only on biopsy and after the extraction of the specimen. And vascular invasion is the one thing which says that it is follicular thyroid carcinoma. Coming to the fourth image, it is of, we can see here there are undifferentiated cells and pleomorphic nuclear pattern is there, and clear-cut tumor cells are there. And this is characteristic of anaplastic thyroid carcinoma. There are tumor cells, and this is highly undifferentiated tumor and carries a highly malignant potential. So option C is the correct one. That is, first papillary thyroid carcinoma is the image 1, follicular thyroid carcinoma is image 3, medullary thyroid carcinoma is image 2, and anaplastic thyroid carcinoma is image 4. Moving on to the next question. 6-year-old boy presents with weight gain, poor academic performance, and physical examination reveals goiter. Bone age is 7.8 years, and TSH of 46, T3.7, and T4 of 4.1. Anti-TPO antibodies are negative. So from here, from the history and from the biochemical investigations, we can say that he's a hypothyroid boy with high TSH, whereas T3, T4 are in the normal range. Ultrasound and TPO antibodies are negative, so it is not autoimmune disease. Ultrasound revealed diffuse goiter with increased vascularity. Since he's a 6-year-old boy, hypothyroid diagnosed as of now, and bone age is not delayed, rather it is little advanced, so it is unlikely to be congenital hypothyroidism. So the other causes which we are left with is the dysharmonogenesis and the autoimmune disease. The autoimmune marker is negative, and there is diffuse goiter on the ultrasound, which favors dysharmonogenesis. So radioiodine uptake scan was performed, which showed more than 50% uptake at 30 minutes and 5% uptake at 24 hours. So this is a typical of one condition, that is, there is a very high uptake in the beginning with a rapid washout on the RAI scan and negative perchlorate discharge test. So the correct answer is urinary monoiodotyrosine and diiodotyrosine measurement, because it is DHAL1 mutation. It is dehalogenase defect, and it is the characteristic of dehalogenase defect is that there is rapid uptake in the beginning. There is very high uptake in the beginning and rapid early washout of the iodine. The option A, that is perchlorate discharge test, it is used to diagnose iodine organification defects, and the most common of which is the anti-TPO enzyme defect. In iodide organification defects, there is high uptake, but rapid, very high washout is not there. The washout is seen only after perchlorate discharge test. And in this patient, the perchlorate discharge test was negative, which rules out iodide organification defects. Option B, that is saliva to plasma iodine 125 ratio. This test is done to diagnose sodium iodide importer defects. But in this disease condition, there is absent RAI uptake. The patient should not have shown any uptake on the RAI scan. And since this patient had shown uptake, so this excludes the diagnosis of sodium iodide importer defect. And the last condition, that is DOX2 gene analysis. It usually presents with transient hypothyroidism, which is only subclinical, and patients are usually diagnosed only on the incidental thyroid function tests. They are usually asymptomatic and no goiter is usually seen. And it usually presents during the pubertal years. Since this age is this boy is diagnosed in the prepubertal age group and with very high TSH, so this makes the DOX2 gene defects unlikely in this condition. So the correct answer is urinary monoiodotyrosine and diiodotyrosine measurement, because in dehalogenase mutations, high concentrations of monoiodotyrosine and diiodotyrosines are found in the urine, and it is diagnostic of the DHAL1 defect. Coming to the next question, 42-year-old gentleman, known case of Graves' disease, presents with swelling both eyes. So this is a clear-cut case of Graves' orbitopathy, and all of the following agents have been tried in the treatment of this condition except anti-TNF agents. Yes, they have definitely been tried. A lot of anti-TNF agents have been tried in the treatment of Graves' orbitopathy, with some evidence is there with etanercept that it reduces the severity of Graves' orbitopathy, but we do not have evidence for reduction in the exophthalmos. Anti-IL-6 receptor antibody, that is tocilizumab, it has also been tried in the treatment of Graves' orbitopathy, with some success shown in various trials that tocilizumab definitely reduces the activity as well as severity of Graves' ophthalmopathy. Anti-IL-1 receptor antagonist anakinra, this has never been tried, and this cannot be used also in the treatment of Graves' orbitopathy because IL-1 doesn't play any much role in the pathogenesis of Graves' orbitopathy. And anti-CD20 monoclonal antibody, that is rituximab. We all know that rituximab has been tried and it is being used also for the treatment of Graves' orbitopathy because it reduces the activity of disease and it reduces the severity to some extent. So the correct answer is C, that is anti-IL-1 receptor antagonist, that is anakinra. Coming to next question, 58 years old lady presented with thyroid 4 thyroid nodule. FNAC revealed papillary thyroid carcinoma. On imaging, it was a local disease without any metastasis and total thyroidectomy was performed. Stimulated whole body scan at 6 months showed uptake in the thyroid bed and stimulated thyroglobulin was 120 nanograms per ml. So it clearly shows that there was a residual disease, and so the patient was administered radioiodine therapy. And as per the protocol, after 1 year, stimulated whole body scan was performed and it was normal, but stimulated thyroglobulin was very high, that is 200 nanograms per ml, and levels of more than 100 or 150, they clearly indicate a metastatic disease in papillary thyroid carcinoma. So PET CT was performed. So as highlighted here, these are the metastatic deposits which are present. There is some uptake in the thyroid bed. These are the deposits which are present in the mediastinum. So this is radioiodine refractory disease because patient was administered radioiodine before and there was no response till the thyroglobulin levels increased. And since the whole body scan was normal, it clearly showed that it is a RAI refractory disease. It is a case of RAI refractory disease. And now the guidelines say that in the patients who are radioiodine refractory PTC, there is no much role of re-administering very high dose of radioactive iodine because anyways, it is not going to be taken up by the tumor cells. So we need something else. So what are the various options? That is option A, re-administer high dose iodine 131. Since this is the RAI refractory disease, so re-administering high dose of iodine 131 is not going to help. Cabozantinib, this chemotherapeutic agent has been approved in the treatment of medullary thyroid carcinoma. Since this patient is having papillary thyroid carcinoma, so cabozantinib is not the correct answer. Lenvatinib, this agent is approved by the US FDA for the treatment of RAI refractory metastatic differentiated thyroid carcinoma and especially papillary thyroid carcinoma. So it is the correct answer. Now these chemotherapeutic agents are the latest drug of choice for the treatment of metastatic thyroid cancer. Maybe it is MTC or the PTC when the patient is not responding adequately to radioactive iodine. For medullary thyroid carcinoma, we have cabozantinib, and for papillary thyroid carcinoma, we have lenvatinib. Radiotherapy, it is doesn't play much role in the treatment of thyroid cancers, and radiotherapy is not recommended as a option for treatment in thyroid cancer. So correct answer is lenvatinib, which is approved in RAI refractory metastatic differentiated thyroid carcinoma. Coming to the next question, 42 years old gentleman who is on a myodron for the past 18 months for intermittent VT presents with fatigue, weight loss, tremors. On examination, there is a firm neck swelling with multiple nodules. And which of the following biochemical scenario is most likely? So it is a case of a myodron-induced thyrotoxicosis. Since this patient is having multinodular goiter and becomes thyrotoxic because of a myodron, so we have to choose which option is correct amongst these. So he's a thyrotoxic patient, so TSH has to be low. The confusion is regarding the FT4 and the FT levels. So this is the table from the article in European journal, and it has clearly shown that in the patients who are on a myodron, maybe it is a short-term therapy or the long-term therapy, If the patient is on long-term therapy, the TSH is either normal or low. So this patient had thyrotoxicosis. So TSH is low because of that. And coming to the T4 levels, these can be increased because of the myodron effect, and it is due to inhibition of hepatic deiodinase 1 activity. And in the long-term therapy, the T4 levels are slightly increased or high normal. If we see the T3 levels, these are decreased in a myodron-induced thyrotoxicosis. It is because of inhibition of, again, hepatic D1 activity, because D1 is the enzyme which converts T4 to T3 deiodinase. So free T3 levels are slightly decreased or low normal. These are never elevated in myodron-induced thyrotoxicosis, and reverse T3 levels are rather elevated. So free T3 levels are either normal or decreased, and reverse T3 is elevated. And this is the characteristic of myodron-induced thyrotoxicosis. And this article was published in European Thyroid Journal in 2018. So the correct answer is option C, that is TSH low, free T4 high, and FT3 high normal. Coming to the next question. This is a case of a 22 years old boy, known case of Graves' disease, presents with thyroid-associated ophthalmopathy, who presents with pain and redness in eyes and clinical activity score of 6 out of 10 with moderate disease. So CAS score of 6 out of 10 indicates that the disease is active. And in the severity wise, he's acting a moderate disease. So MRI orbits was done. So which MRI image is most likely? So I would like to tell here that in MRI of Graves' orbitopathy, there is characteristic thickening of the belly of the ocular muscles, extraocular muscles, and with sparing of the anterior tendon. If you can see here in option B, there is thickening of the muscle belly with sparing of the anterior tendon on both the eyes. And this is also called as the champagne bottle sign. That is, there is a formation of a
I think he got logged out.
Yes, ma'am, he's not logged out.
The left, I'm not sure.
No, he got logged out by mistake, not left.
Questions were left, I'm wondering.
Yes, questions were left, yeah.
कितने रह गए थे?
2 or 3, yeah, 3 were left.
If somebody can call him, I'm already on the phone actually. There's
Yeah,
something.
I'm just, ma'am, I'm trying to call him.
I think maybe he's back. Have you called him?
Just call.
Otherwise, we can announce the winners and.
Ma'am, he is joining in 1 minute.
Okay. He has started, yeah.
Welcome back. Go ahead. Arpit, we can't hear you. We can see your screen.
Yeah.
Yeah. Just don't worry.
Yeah. So as I was discussing here, we can see in the option B, in thyroid associated ophthalmopathy, there is thickening of the muscle belly with sparing of the anterior tendon. And option B is clearly showing here the thickening of the belly with sparing of the anterior tendons. which are attached with the eyes. And this is also called as the champagne bottle sign, and it is characteristic of the thyroid ophthalmopathy. If you see the option A, there is thickening of the entire muscle. There is thickening of the muscle belly as well as involvement of the tendon also, and sparing of the muscle on the other side. So it is a case of orbital pseudotumor. And if we see the option C, there are deposits of the lymphoma. If we can see here beneath the eyeball, there are deposits in the whole of the muscle. There is thickening of the entire muscle belly and the tendon, and the deposits are all around and in both the eyes. It is characteristic of a distant metastasis of lymphoma. And if we see the option D, there deposits are present in the apex hair. So small deposits are there, and these are again images of the orbital metastasis. So the thing which we should know here is that the typical finding of Graves' ophthalmopathy is the thickening of the muscle belly with sparing of the anterior tendon, also called as champagne bottle sign. Coming to the next question. 7-year-old girl presents with vaginal bleeding. There is history of poor height gain and excessive weight gain. On examination, there is no thylarch or pubarch. Bone age is 5 years. So from the history, it is a case of precocious puberty because a girl is having vaginal bleeding, but there is no thylarch or pubarch. Only menarche is there, and there is delayed bone age. So differential which comes to our mind is immediately hypothyroidism. And if we can see here, LH is low, FSH is normal, and prolactin is elevated, which is 122 nanograms per ml. TSH of 146 milli-international units per liter, and TO3 is low, T4 is low. So it is a case of primary hypothyroidism. The prolactin is elevated, we know, because of the reverse feedback, because of elevated TRH, which causes high prolactin levels also. And this is the case of Van Wyck-Grumbach syndrome, in which the high TSH, it cross-reacts with the gonadotropin receptors, particularly the FSH receptors. And due to the stimulation of the gonadotropin receptors, there is increased in the secretion of the estrogen and the sexual hormones, which lead to the precocious puberty in these girls. So the option A is Van Wyck-Grumbach syndrome. It is correct because this condition is also called as the Van Wyck-Grumbach syndrome. It is due to the TSH cross-reactivity with gonadotropin receptors, as I've told, can present with heterosexual puberty or precocity also. It is false because this can never present with heterosexual precocity. Heterosexual precocity means that there is the early emergence of the pubertal features of the opposite sex. Like if there is early pubarch in the girls, then it is called as a heterosexual precocity. If there is early menarche or early thylarch, then it is the isosexual precocity. For appearance of the early pubarch or early genital hairs, there has to be increased amount of the DHEAS in the blood, which cannot occur in this syndrome because it is due to the cross-reactivity of TSH with the gonadotropin receptors. So since the hormones are coming only from the ovaries, there are increased levels of estrogen only, and this leads to isosexual precocity. In males, this can present with macroorchidism because increased TSH will cross-react with the gonadotropin receptors, and it will increase LH will be there, and it will increase the size of testes. So it will present with macroorchidism in males and vaginal bleeding in females. So it presents only with the isosexual precocity. Treatment with levothyroxine replacement alone is needed. Yes, that's the correct answer, because only treatment with levothyroxine replacement will normalize the TSH, and it will prevent the positive feedback on the gonadotropin receptors, and thus there will be inhibition of the HPG excess, and the precocious puberty will revert back. There is no need to start GnRH analogs in such patients. Only thing which we have to do is the initiate treatment with levothyroxine. So the correct answer is option C, that is can present with heterosexual precocity, because it is false in this patient. Moving on to the last question. Which of the following statements is true regarding the timing of prophylactic total thyroidectomy in MEN2 patients? Option A, RET M198T mutation. Option B, option A, that is total thyroidectomy at or before 2 years of age. So in this in these patients, we have to know that there are 3 kinds of mutations which are classified like moderate risk, high risk, and highest risk. So this is the table from the American Thyroid Association guidelines. The RET germline mutations in children who are at a risk of developing MEN syndrome, they have been classified into moderate risk, which is MOD, high risk, which is H, and highest risk, which is HST. MOD includes the mutations like 609 and 620F. The high risk mutation is the 634F, and the highest risk is 9180 mutation. And the patients of MEN2B, most of the patients, they carry highest risk mutation, that is the 9180 mutation. Whereas patients of MEN2A, they can carry both high and moderate risk mutation. That is, high risk is 634 and moderate risk is 609 and 620, and many others are there. So in patient with highest risk mutation, that is 634 mutation, the total thyroidectomy has to be performed as early as possible, ideally less than 6 months of age. In high risk mutation, that is 634F, the total thyroidectomy has to be performed at or before 5 years of age. And in moderate risk mutation, that is 609, 620, and other mutations, the total thyroidectomy can be performed when serum calcitonin levels become elevated, or in childhood if the patients do not wish to embark on lengthy period of evaluation, which might last for years or decades. So there is no need for definitive total thyroidectomy in moderate risk mutation, whereas in high and highest risk mutation, you have to perform prophylactic total thyroidectomy. So the correct answer in this patient is option C, that is RETC 634F mutation, which is high risk mutation and total thyroidectomy at or before 5 years of age, which is the correct answer. So we have come to the end of today's quiz. Now I'm going to share the screen for the, just a minute.
Karthik, you will have to stop sharing. So I'll stop your sharing from here.
Yeah. Should we start the answers for the thyroid teaser also?
Yes, sir. I'm just checking.
Should we go ahead with the answers of thyroid teaser also?
Yes, ma'am. Yes, sir. Sir, ma'am, shall we go ahead with the answers for the teaser questions as well, ma'am?
Yes, absolutely.
Yes.
So the first question was, all the following drugs alter the T4. Just a minute, I'm going to the answer part. So the first question was, all the following drugs alter the T4 absorption except option A, sucralfate, option B, aluminum hydroxide, option C, glucocorticoids, and option D, omeprazole. So out of these drugs, we know that sucralfate definitely alters the levothyroxine absorption. Option B, aluminum hydroxide, which is a component of many antacids, oral antacid syrups, which we drink. It is a part of that, and it definitely impairs the levothyroxine absorption. Option C, glucocorticoids. These drugs do not affect the absorption of levothyroxine, but glucocorticoids can definitely alter the thyroid function test by various other mechanisms. And omeprazole, this is a proton pump inhibitor. It definitely alters the levothyroxine absorption. So the standard guideline, which we say that if you are taking any of these drugs, then you have to keep a gap of at least 4 hours. That is, you should take levothyroxine in the morning as soon as you wake up. And if you're taking any PPI or something like that, you can take that at least 4 hours after taking levothyroxine. So drugs causing thyroid dysfunction. If we see here, the various drugs which decrease the T4 absorption, these are cholestyramine, cholestyramine, sucralfate, ferrosulfate, aluminum hydroxide, omeprazole. The second question was, I urge a child born to a hypothyroid woman at 37 weeks. She had TSH of 20 at 32 weeks, anti-TP antibodies more than 1300, started on 100 micrograms of levothyroxine. Neonatal screening for congenital hypothyroidism was not performed in the baby. However, at 2 weeks after delivery, when the child was shown to a pediatrician. Detailed evaluation of the newborn was done, and this TSH was 13 at 18 days. What should be the appropriate next step? Option A, start levothyroxine immediately. Option B, start levothyroxine immediately and send samples for free T4 and free T3. Option C, repeat TSH after 2 weeks. And option D, reassure and remeasure TSH at 3 years of age. The correct answer is repeat TSH after 2 weeks. So this is the table from the ISPE guidelines.
I think we are not seeing the slides. There is no slide which is there. So we haven't got the slides on the screen.
Just a minute, there is again interruption, I think. Just a minute, I'll share it again, ma'am.
No problem. You can go ahead with the second question. It's okay.
Are the slides visible, ma'am, now?
Now it is visible. Yeah, you can just make it full screen and present. Yeah, that's
so the question was regarding IUGR child who in which the congenital screening for congenital hypothyroidism was not performed, and the child had TSH of 13 at 18 days. So what is the appropriate next step? So this is the table from the chart from the ISPE guidelines of congenital hypothyroidism. If TSH is less than 20, if the TSH is less than 20, so we have to see in case of 20 to 40, less than 20 after 72 hours is normal. But if we see at the age of 18 days, that is after 2 weeks. So after 2 weeks, if the TSH after 2 weeks is less than 10, it is considered as normal. But if the TSH after 2 weeks is more than 10, then we have to repeat the TSH. TSH persistently more than 10 after the age of 3 weeks with normal T3, T4, we have to start the treatment and reassess after 3 years of age. Elevated, if the initial T4 is normal and high TSH, elevated TSH for age, that is more than 20 for less than 2 weeks and more than 10 for more than 2 weeks with normal T4, then we have to repeat TSH after 2 weeks. So if the child is having elevated TSH in normal T4, we have to see whether it is normal for age or elevated for age. The cutoff for normal and elevated is 20 more than, if the child age is less than 2 weeks, we have to, the cutoff is 20, that is more than 20. And if the child age is more than 2 weeks, then the cutoff is 10, that is more than 10. Since this child had the TSH of more than 10 at more than 2 weeks of age, we had to reassess the TSH, that is after 2 weeks. And if again the TSH is more than 10, then we have to start the treatment. If the TSH is less than 10, we can just wait and it is considered as normal. Coming to the next question, 44 years old gentleman who presented with generalized weakness, tiredness and disturbed sleep, family history of premature CVD and type 2 diabetes, TSH of 12, T3, T4 normal, and NT-TP of more than 1300. Administration of levothyroxine will reduce the risk of all of the following comorbidities except option A, progression to overt hypothyroidism, option B, weakness and tiredness, option C, dyslipidemia, option D, future cardiovascular disease. So the correct answer is D, that is future cardiovascular disease. This is a table from New England Journal. And there is also an article of subclinical hypothyroidism in NEGM. If we see here, administration of levothyroxine, benefits of treatment, the progression to overt hypothyroidism, the benefits of treatment are definitely there. Symptoms of hypothyroidism, there are inconsistent benefits. However, some benefits are shown in some trials. Surrogate markers, benefits of treatment are there in the markers, whereas for the risk of coronary heart disease, congestive heart failure, stroke, and cognitive decline, there is insufficient data to inform any benefits. So the treatment benefits may not be there to prevent the future CVD. So the correct answer is future CVD. Next question, 26 years old lady presented with weight loss, 10 kg over 6 months, palpitations, hyperdefecation, pain in throat, significant anxiety and depressive features. Her both parents were on levothyroxine replacement for hypothyroidism. On examination, the heart rate is 126, no goiter, no eye signs, and fine tremors are there. Biochemical examination revealed overt hyperthyroidism, and technetium scan was performed. Serum thyroid, the image of the technetium scan is shown here. If we see the thyroid bed, there is no increased uptake. Rather, the uptake is normal or slightly on the lower side. And if you see the serum thyroglobulin levels, it is 0.2 nanograms per ml. And the normal levels are shown here. So the serum thyroglobulin levels are also low. So if we see the differentials of thyrotoxicosis, the main differentials are One is the Graves' disease, which is hyperthyroidism. Second is thyroiditis, and third is factitious thyrotoxicosis. In Graves' disease, there is increased uptake in the technetium thyroid scan, and there are increased thyroglobulin levels. So since there is reduced uptake, it is not a case of Graves' disease. Second possibility, thyroiditis. In thyroiditis, that there is a reduced uptake in the technetium thyroid scan, which is there in this, but in thyroiditis, there are elevated serum thyroglobulin levels. But in this patient, thyroglobulin levels were low, so it is also not thyroglobulin levels. And in a patient of thyrotoxicosis, if both these conditions are met, that is reduced uptake on the thyroid scan and low thyroglobulin levels, it makes the diagnosis of factitious thyrotoxicosis. So the appropriate management for this case would be to start just beta blockers and reassess thyroid function after 4 weeks, because methimazole and methimazole is not needed in factitious thyrotoxicosis. NSAIDs are indicated only in case of thyroiditis. Iodine ablation is not a choice in factitious thyrotoxicosis. In factitious thyrotoxicosis, only thing which we have to do is to stop the intake of the thyroid hormone in any form, and we have to relieve the patient of her symptoms, for which we can give beta blockers for a short period. 22-year-old lady presents with 4 weeks gestation, and there is family history of hypothyroidism in mother. Routine biochemical investigation revealed TSH of 3.7, normal T3, T4, and antibodies are negative. What would be the most appropriate next step? Start levothyroxine, perform free T3 and free T4, reassure and repeat thyroid profile after 3 months, and perform ultrasound neck. If hypervascularity, then start levothyroxine. So as per the latest guidelines from the American Thyroid Association and the Indian guidelines also, in the range of TSH of 2.5 to 4, we have to assess the anti-TPO antibodies. If anti-TPO antibodies are positive, then we may consider giving levothyroxine. But if anti-TPO antibodies are negative, there is no need of giving levothyroxine. So the correct answer would be reassure and repeat TSH, free T3, free T4 after 3 months. There is no need to start levothyroxine. We won't gain anything by performing free T3 and free T4 levels. There is no benefit of doing ultrasound neck in such a patient, unless the patient is having some goiter or some nodules are palpable, then only we need to do ultrasound neck. Thank you. Thanks a lot. Over to Dr. Ganavi for taking the session.
Thank you, sir, for a very detailed discussion of the quiz answers. I now request you to announce the winners. I request the IT team to display the quiz winners.
So I'm very happy to announce the winners for the quiz. The winners for the quiz for 24th May are Dr. Gulnaz Jamdar, Dr. Ashok Sundrani, and Dr. Annapurna Singh.
There'll be one more slide.
25th May also.
IT team.
Can you display 25th May also for today?
Asmita.
Asmita, can we display the today's winner?
Ganvi, can you announce the next program? Not for, I mean, of course, obviously, the one that, the clinics that we are doing.
Yes, we have the closing remarks by Dr. Arun Menon, so I will request. So now I request our Secretary of Indian Thyroid Society, Dr. Arun Menon, sir, to give the closing remarks.
Thank you, Ganvi. I think ma'am was saying, when is the next meeting? I think you could probably say that, and then
Yes,
we can.
sir. Yes, sir. On 14th June, it is there,
14th
sir.
June.
We will be putting up a flyer, so the IT team has a flyer for that. We'll be
okay.
After the concluding remarks.
Okay, thank you. So, and what about the winners for tonight? I think they're still searching for that, isn't it?
Rather than just.
Should I just go ahead or should I wait?
You go ahead.
I think
Okay.
IT team is going to put it soon.
Okay. So maybe I'll just go ahead and thank everyone, because I think that's the most important thing we need to do. So good evening all. Let me thank all the panelists for the first session. Dr. Said Raza, Dr. Shamin Jahan, Dr. Prasad, Dr. Pratosh Gangadhar, and Dr. Saira Lam. It was a very practical discussion on hyperthyroidism and its management. I think it's a very important day-to-day practice points that were discussed. So a very useful session and very ably conducted and moderated by Pramila, as we all expect. Pramila did a wonderful job and ably supported by our Jabbar G as well. So it was a wonderful session. So thank you so much to all the panelists and the moderator. Dr. Shashank Joshi's presentation was wonderful. I think he was really to the point, and he actually brought all the important points in a very short span of time with regards to subclinical hypothyroidism and how to treat it. So thank you, Shashank Ji. We look forward to hearing from you in the next few days. I think it's pretty much the same topic in children. I think he's going to talk on ITS Con, the same topic. Dr. Arpit Garg, it was a wonderful quiz. I think you have, you're a teacher. It's very clear. I think you went through all the questions in such detail. I think, thank you so much for that wonderful quiz. Each and every question was worth its weight on gold. I mean, it really did, it was a lesson in itself, each question. So thank you so much for conducting such a wonderful quiz. Really appreciate it. Let me just remind you all that starting from tomorrow, the ITS Con 2023 in Cochin, we are all looking forward to hosting you. It's still not too late. If you can still catch a flight and be in Cochin. So please come and join us. It's going to be 2 days of very interesting topics and wonderful speakers, and we have chosen the best that we can. So please do join us if you can. We all look forward to hosting you in Cochin over Saturday and Sunday. So thanks and good night from my side. I think Asmita is going to show us the winners from. Yeah, Arpit, it's your yes, privilege to announce the winners.
So I'm very privileged to announce the winners for the today's quiz. So the winners for the today's quiz are Dr. Lakshmi S, Dr. Shruti R, and Dr. Anima Sharma. Congratulations to all the winners.
So thank you once again. I think Ganvi, over to you for final remarks.
Yes. So Asmita, can we have the next? Yeah. So we will be having the next thyroid clinics on 14th of June. So where Dr. Shanmugam Sundaram sir will be chairing the session and Dr. Kripacharian madam will be moderating it. So it is a panel discussion on salt iodization, diet and lifestyle in thyroid. We have international faculty with us for the panel discussion. Dr. Nazmul Qureshi sir from Bangladesh, Dr. Matullah Khan sir from Pakistan, Dr. Santosh sir from Nepal, and Dr. Manilka sir from Sri Lanka. Followed by that, there will be a quiz, and again, the panel discussion will continue. So with that, and then we have the upcoming thyroid clinics on 12th of July, 9th August, 13th September, 11th October, 8th November, and 6th December. So stay tuned for all of these dates. So with that, with Madam's permission, we will be concluding the session.
You can call it a night.
Thank you. Good night.
Thank you.
Good night, everyone. Good night.
Night, everyone.
Good night.
Ganvi. Thank you, Asmita. And thank you to.
Thank you, ma'am.
Thank you, ma'am.
Good night.